I would just like to introduce our final speaker for today, Dr. Kylie Chimes. Kylie is a specialist clinical and laboratory haematologist at St Vincent's Hospital and Austin Health. She completed her specialist haematology training at St Vincent's Hospital in Melbourne and at the Peter MacCallum Cancer Centre. She is currently undertaking a PhD in supportive care and transfusion medicine. And Kylie's research work is part of the NHMRC Blood Synergy Program at the Transfusion Research Unit of Monash University. Dr. Chai is committed to providing the best possible care for her patients. Thank you, Kylie.
Okay, thanks, Catherine. Can I check? Can you hear me okay?
Yeah.
Okay, wonderful. All right. Okay, let me know because the audio is sometimes goes a bit crazy on my computer. So, okay, great. And hopefully you can see the slides okay as well. Alrighty. So thanks for inviting me to present today. I'll be sort of focusing a little bit on immunoglobulin replacement in myeloma because that's the topic of my research. But before that, we were hoping to sort of discuss, how does myeloma affect the immune system? How do we reduce infection risk in myeloma? I'll just advance the slides. What are some of the current approaches to immunoglobulin prophylaxis in clinical practice in Australia? And just having a quick look at, are there any ongoing research or clinical trials looking at IG in this space? So I guess firstly, how does myeloma affect the immune system? We often talk about, increased infection risks for people with myeloma. So you might have heard the term immunocompromised. So people with an weakened immune system, including people with myeloma and other blood cancers, are sometimes described as being immunocompromised or having an increased susceptibility towards developing infection. There are many factors for why this develops. You can see on the screen here on the top right, there are disease-related factors as well as patient-related factors, and there are also treatment-related factors as well. So firstly, in terms of the underlying myeloma disease process, why do people with myeloma develop increased risk of infections? I guess firstly, plasma cells or myeloma cells are a type of white cells and part of the immune system. And we need healthy plasma cells to produce useful antibodies or immunoglobulins, or IG for short. And these antibodies are very important in helping to fight infection. When people have myeloma, they make abnormal plasma cells, and as these plasma cells multiply, they don't make normal, healthy immunoglobulin or antibodies. Instead, they make large amounts of a single type of antibody called a paraprotein, and it doesn't function normally, and therefore there can develop something called acquired hypogammaglobulinemia or reduced antibody levels, and that can lead to an increased risk of developing infection. Apart from that, specific types of treatments can also affect the infection risk. So on the top left, you can see the neutropenia and lymphopenia. So neutropenia refers to a low number of neutrophils or low number of white cells, and specific anti-myeloma treatments can often lower the types of these specific white cells for people who receive these treatments. Therefore, when there is less white cells, there may be less cells targeting a specific type of infections. And people can often develop specific types of infections with specific types of treatments as well. So in the bottom left there, in terms of treatment-related factors, things like, how much steroid you might be on, things like having intensive treatment such as high-dose chemotherapy or autologous stem cell transplant can also affect the infection risk. Nowadays, with newer targeted treatments, including things like CAR T cells or anti-CD38 antibodies or other types of more targeted treatments, I think we're still trying to, our understanding of what types of infections people may experience with these newer types of therapies is still evolving as well. In terms of the myeloma disease process itself, so we can also see that during remission, when people might have myeloma under control, the immune system might recover as well, so that infection risk might improve to a certain degree. So what are some of the common interventions that we commonly see to reduce infections in myeloma. So I guess firstly, having understanding what some of the signs and symptoms are of infections is important, and seeking early medical attention and review. So recognizing, what might consist in early infection. So things like monitoring temperature, recognizing that a high temperature over 38 degrees or having a very low temperature less than 35.5 degrees might be an early sign of infection. Things like knowing what symptoms might herald an infection, things like having a sore throat or a blocked nose, or having a burning sensation when passing urine, things like that, may prompt someone to seek an early medical attention. So if access to a nurse practitioner or a doctor at your center would be important. There are also some behavior modifications that can help reduce infection risk. So this might include things like regular hand hygiene, before food preparation, for example, or after being out in public spaces is important. Oops, sorry, I've got to advance the slide. Here we are. And also things like food preparation is important. Things like keeping raw and cooked meat separately as well is important in this aspect. And also bearing in mind, what are some of the things that we can do to reduce the risk of infection? Things like perhaps avoiding crowded public spaces might be important as well, or perhaps using public transport during sort of less busy periods may also be helpful. There are other specific types of interventions that can reduce infection risk. So apart from hand hygiene and social modification, things like prophylactic vaccinations, use of prophylactic antibiotics or antivirals in specific cases, as well as use of prophylactic immunoglobulin therapy may sometimes be recommended by your health practitioner. In general, vaccinations that are recommended for people with myeloma include inactivated vaccines. So things like influenza vaccine once a year, five-yearly pneumococcal vaccine, COVID vaccines is generally recommended. Also bearing in mind that there are specific types of vaccines, such as live vaccines, that are contraindicated for people with myeloma as well. So we've done some studies looking at prophylactic immunoglobulin in people with myeloma. So I wanted to focus on that for the next part of the talk. So I guess firstly, what is immunoglobulin treatment? So hopefully you can see that. So our body makes antibodies or immunoglobulin as part of as a critical part of the immune system. But immunoglobulins can also be manufactured commercially and prepared from large pools of donated human plasma. And this usually goes through quite a complex preparation process that includes things like fractionation, so separating out different part of the donated plasma, stabilizing the blood product, as well as inactivating viruses. And this can be used to prepare intravenous IG or IVIG, as well as subcutaneous IG or SCIG. IVIG and SCIG can be used in a wide variety of conditions, but for people with myeloma, it can be given once a month or every week, depending on its preparation, to try and replace the amount of antibodies in people's blood. There are also other types of preparations that can be prepared, such as hyperimmune IG, but this is generally used to treat specific types of infections. So I guess why is this important? So we know that IG replacement can be used for people in blood cancers, and we have specific access criteria as released by the National Blood Authority in Australia. We know that the use of IG has been rising over the last 10 years, and people with blood cancers account for the largest users of IG in Australia. I think there are still lots of variation in what happens in clinical practice, and we're still trying to understand how best to use this blood product to fight infection. Okay, yep. So in terms of how we use this in clinical practice, there was a recent survey that was conducted as part of the ALOG supportive group. And this survey was done probably about 5 years ago now. And this survey was sent around to clinicians or hematologists within Australia and New Zealand to try and understand, what are some of the treatments that they commonly use to prevent infections. And you can see there that hopefully you can see on the graph on the right that there was a combination of treatments that people commonly administered to prevent infections. So this might include things like RBIG, SCIG, vaccinations, and prophylactic antibiotics. What they also found is that the approach to replacing IG was quite different amongst clinicians, and this might reflect differences in local policies governing access to IG. So, for example, people or clinicians practicing in specific areas within Australia and New Zealand might be more likely to give IG versus people in other areas may be more likely to recommend prophylactic antibiotics, for example. Interestingly, also, there's also been a public summary document released in 2019. So, following that survey released by the MSEC committee, whereby they identified that yes, we do commonly use IG and other treatments to reduce infections for people with myeloma, but there were a lot of uncertainty about how best to use this product. So what we know is that there needs to be further research in specific areas, including when to start IG replacement, how long to stay on IG replacement for, as well as it's the role of IG in other types of blood cancers apart from myeloma, including things like lymphoma. Sorry, I forgot to advance the slide. So this was the MSEC document there that looked at some of the evidence gaps. Okay, so what I wanted to look at next was really, I guess, just trying to understand what the best evidence for IG is in the current climate. So what we did was a number of years ago, we performed a systematic review at Monash University in conjunction with the ALOG group. Essentially, what we did in this review was we looked at, what are some of the best evidence for use of IG and what are some of the best evidence for use of things like prophylactic antibiotics and vaccinations for people with blood cancers, including myeloma, including chronic lymphocytic leukemia and lymphomas. And we tried to see, does this treatment, we included evidence from randomized controlled trials, which is the gold standard for clinical trials. And we look to see, does using IG, antibodies and vaccinations, does it reduce infections for people on clinical trials? And is there any effect on safety? All right. So when we looked at the evidence looking at IG, antibiotics, and vaccinations, we found 21 trials that had looked at these interventions. And interestingly, for evidence on IG, most of the trials were actually conducted quite a long time ago. So for the trials looking at IG use, a lot of the trials were done before the year 2000 and looked at quite small numbers of people. So 370 patients were included on these clinical trials. And when we looked at the evidence for antibiotics, there were more patients included. So over 1,000 patients were included on these clinical trials. And looking at vaccinations, you can see that the number of patients included, that is over 3,000 patients, had looked at prophylactic use of vaccinations. So again, I don't want to sort of spend too much time on the specific numbers here, but what they found was that what we found in the studies on immunoglobulin, again, you can see 8 studies, 7 before the year 2000. The studies on IG use did reduce the risk of clinically documented infections. So we found that there was a good effect on reducing the risk of infections for prophylactic use of IG. For the trials looking at antibiotic use, again, we didn't find a reduction in the use of clinically documented infections, and this is for people taking daily antibiotics as prophylaxis. And for the trials looking at vaccinations, yes, we found that there was an effect on clinically documented infections there. All right. But when we looked at some of the trials itself, again, a lot of the trials were published over 15 years ago. So before the and also a lot of the trials were really quite small. So essentially, from the systematic review that we did, we agree with the MSEC findings is that we do need more research in this space to try and understand how best to use IG now that we have more targeted therapies available. Okay. Next, I wanted to have a look at how we use IG in clinical practice. So not looking at just clinical trials, but looking at patients with myeloma not on trials in Australia and New Zealand, as well as how we use IG in other countries. So in this study, again, I won't focus too much on the fine details of the study itself, but I just wanted to touch on how clinical practice might differ across regions. So when we looked at patients with myeloma that were enrolled on the myeloma, so the MRDR, the Myeloma-Related Diseases Registry, we had patients in Australia, New Zealand, Singapore, and Korea. And when we looked at the time of diagnosis to when they started IG, we found that the rates of IG use in different countries were actually quite different. And secondly, when we look to see, is there anything that might predict for use of IG amongst people with myeloma in these countries? I'll show you on the next slide, but in that there were specific types of treatments that were more likely to be associated for IG as well. When we looked at the use of IG within states in Australia, we also found that IG was quite different. The likelihood of receiving IG was quite different depending on which state you were receiving treatment in as well. So essentially, there is a lot of variability in how clinicians are using IG in this space at the moment. Which brings me to the next slide. So I just wanted to end with, I guess, a few updates on where we're going in the research space. So, I think we at the moment, we do believe that IG is beneficial to reduce infections, but what we're trying to understand is, which how is it more likely to be of use in specific types of treatments, and how long do we need to continue IG for? So clinical trials that are currently ongoing include the Rational Platform trial, which is being run out of Monash University. And then this trial is actually recruiting at several sites across Australia, New Zealand, and Canada. So on this trial, we're trying to understand, how long should we continue IG for once we started IG? And is there any specific factors that might predict for a better outcome with IG for people with myeloma? There are also a number of sub-studies that we're conducting as part of this trial as well. So as part of this trial, we're also conducting a qualitative study whereby we're trying to understand from people receiving IG, what is IG doing for you? Are you having, what are some of the barriers that you're facing if you are receiving IG? And what are some of the barriers that you might face if you stopped IG? Or, is there anything that makes it easier or more difficult to receive treatments such as immunoglobulin and or prophylactic antibiotics? So this trial is currently ongoing, but I thought it was important to include just that we know that there's ongoing research in this space for us to try and understand how best to improve the patient experience for supportive care treatments, including IG and prophylactic antibiotics. So just bringing us to the last slide. Essentially, we know that people with myeloma increased risk of developing infections through a number of factors, and that might include things like disease-related factors, as well as treatment-related factors. And there are some common interventions that are used to improve the infection risk, and these include things like immunoglobulin treatment, as well as vaccinations, and maybe use of prophylactic antibiotics in some cases. But we know that ongoing work is required to improve the understanding of how we're currently using IG in this space, and trying to understand what the patient experience is, trying to improve make it easy for people to receive ongoing treatments such as this, because we know that there's a lot of time required in hospital to receive immunoglobulin treatments and other supportive care. But that's the last slide. So I think we are on time, hopefully, at 2:30. Thank you.
It's such an informative session, and we can see that the use of immunoglobulins is so wide and varied, and obviously will likely, with the research you've shown, change in the future as well. And I know one of your research pieces was about how long someone should continue immunoglobulin therapy for. Is there any current recommendations around that, or is that obviously why you're looking into that with your research?
Yeah, so I think there is this criteria for access to IG that's published by the National Blood Authority. But I think we don't really understand from clinical trial work as to, how long someone should stay on IG treatment for. And of course, there's a lot of factors that play into that. How stable is the myeloma? What treatments are they receiving at the moment? Um, I think a lot of the time the decision is made to clinicians to decide on a case by case basis. And I didn't really show that in the slides, but that's what we picked up from that clinician survey that was done by the ALG a number of years back. And is that how clinicians took patients off was quite variable. Some people might choose to take them off if they've been infection free for a period of time, or some clinicians might choose to take people off IG if their disease was stable, or some people might choose to take people off if, for example, the IgM or IgA levels had risen to a specific level. And some people might choose to take people off IG at, in specific times of the year. So say, when it's not winter, for example. So there was a lot of variation in how this is done in the hospital setting. And that's sort of part of the reason why we are hoping to sort of collect more sort of evidence-based information to help guide clinicians as well as patients who may be receiving these treatments for a long period of time to
Yeah,
see who
hopefully.
be safely. Yeah.
Yeah, it is such a precious resource. So hopefully we have some, guidelines for better guidelines for use in the future. Just one last question as well, in relation to subcutaneous IG versus intravenous IG. Is there any differences in effectiveness in the use of these?
Yeah, look, I don't think we know. They, the studies that have looked at both intravenous and subcutaneous have been focused on, patient experiences, and there hasn't been any sort of head-to-head data in the myeloma space, as far as I'm aware. I think the thought is that with the subcutaneous replacement, perhaps the levels are more steady because of the weekly injections versus the monthly infusions, but I don't think we can extrapolate from current trials as to which is more superior at the moment.
Okay. Well, thank you so much, Kylie. We really appreciate your time today.